we'll go to this. Let me just share the screen and we will jump into the presentation. All right, I believe you can see my screen now. And now let's present. So, thank you very much for having me today. And it's an honor to give this talk during your graduation ceremony. And since you all had a quite intense time of research mentorship, let's end this beginning with a research paper presentation or with the design of a journal club. So this is a presentation that has as a title the well-known quote of Hippocrates, the first scientific physician: art of medicine is long, but human life is short in comparison to this. So we all have a short life in a long art that extends beyond us and that inspires us to go on in this pathway. And all of us are quite young in our careers and also in our lives. So what we can discuss today, from my perspective, but also from your perspective, is the preliminary results of a clinical, academic, and societal trial, because we are all involved as clinicians in the future, also as researchers. This is why you're here, and we're all members of the society, active or less active. And I would call this pragmatic because it's not something that we design in a tube. Everybody's here with their own circumstances, their own background, their own needs, and this is what in reality would be a pragmatic clinical trial. But it's not only a clinical trial. So without further ado, let me tell you that in this presentation, I will narrate some examples from my pathway until today, and there will be many changes. So nothing will be as it seemed in the beginning. In a study, we should, of course, first start with the abstract after the title. So in this presentation, I will talk about my plans before getting into medicine, my medical studies, then my undergraduate education, where I had the chance to get involved first in clinical medicine, then in public health or public health affairs, in research, what happened in COVID. This is how we met with Dr. Faisal. My graduation and my job search and my current situation after I moved and started working abroad about 2 years ago. And the keywords here are, or the main pronouns about me are orthopedics. This is my main job. Public health. This is my postgraduate study and a big part of my free time. Global surgery in the sense that I'm trying to combine them somehow. Health policy and medical humanities. Medical humanities, you will realize at the end why. So let's start with my early years. I'm not so old, I'm 26 years old, but in high school, I actually wanted to study law. So I was in the humanities orientation. I didn't have maths, biology, physics, and so on. I had ancient Greek, history, literature, and there were two reasons for this. One reason was that I was genuinely interested in these subjects in humanities rather than in the so-called scientific orientation at the time. The second reason was that in my family we had a lot of, let's say, we didn't have any physicians, but we had a lot of experience with informal caring of elderly relatives. And through this experience, I actually did not have decided that I do not want to get involved in healthcare anymore, in caring, and so on. And what changed my mind to a great extent was that at the last year we went through some, fortunately not serious medical issues with my mother, who was also my tutor in ancient Greek and so on. This is her main job. She's a classicist. And many people would say that at some point you get inspired by a doctor. In reality, I got de-inspired by the doctors that we met. And and despite all this, I managed to have a very good score at the end of the university entrance exam, and this allowed me to study medicine, although it was not the initial plan. And therefore, I decided to give it a try. So this is why the admission was unexpected, and but still, even after that, and although I didn't have my best time with biology, physiology, and so on at the beginning, I tried to put the elements of my previous life, which was humanities, literature, poetry, fiction, and so on, into practice within the new field of study. For these reasons, I started quite early trying to write and publish in medical blogs, student magazines, and so on. And I also developed the good inclination and tendency to try to have internships abroad, either at clinical or research settings. And through that, I got also to know students who were at that time organizing conferences. And you might know that in students' conference, there is a big tradition of having an ambassador of the conference in other countries. That means that a conference participant is also inviting other people from his university and country to join that conference abroad. And knowing some of the organizers of the conference, they invited me to their countries and also recommended me to join their conference as an ambassador. So this was something that I also did. And through this, and given of my interest in writing, although at that point I only had rejections in anything I wrote, because of course I didn't know how to write, I applied for an editorial board membership in the student medical magazine or journal of the Association of European Medical Students. And through that, I had the chance to get to some more hands-on experience on how should one write and communicate, because my writing style until then was the one that we had at the Greek high school in order to write an essay that enables us to get into the university, and this is not the case in medical writing. And at the same time, I got also inspired by some specific futures in the university that persuaded me that I was probably in the right place. One of them was the neuroanatomy class, where the neurosurgeons that taught it had a big talent in not only teaching their subject, but also inspiring people to find their call or their mission in the field. And we made with them a neuroanatomy teaching team that also conducted research and had also a very active presence in organizing debates about neuroscience, mind, and body, and so on. And at the same time, I also joined the Medical Humanities Elective, which was an opportunity to remember what I wanted to do before school, within school. So this is how the first 2 or 3 years of my studies passed, with a lot of doubt, but also with many interesting encounters. And after that, with the clinical years, I had the opportunity to get to know more people, increase the percentage of involvement in conferences, in publishing, in research, not always in a smooth way, and also in public health. This photo here is a fast forward, but it testifies of the spirit of meeting like-minded people, getting out of our casual or our conventional university studying, and creating something that can go places, can go. This is a photo from the WHO headquarters in Europe, in Copenhagen, and this is our proposal for labeling of alcohol beverages. And this all as a mentality started at the, more or less at this point in the clinical years, when I realized that medicine was not only about the hospital and the laboratory, but also about developing networks with people and creating together with people. Of course, this comes with a lot of conflicts in terms of schedules and also in terms of decisions, like what should I do, with whom people should I work with. Of course, participating in conferences, sometimes good, sometimes bad, going more abroad, and also receiving negative feedback. I was at that time I was posting a lot on Facebook about conferences, about presenting there, and so on. And many of my classmates and unfortunately also some distant family who were into medicine were very displeased with that and criticized me about that. That was the point when I realized that Facebook, with all the people without a medical background, is probably not the best platform to share all these projects. And instead of stopping sharing, as they recommended me, I moved on to other platforms like LinkedIn and Twitter. And at that point, I believe I first met a person who has conceptualized a hashtag about AI in medicine. This person is also on this call, and you all know him. And at that point, I also managed to publish my first peer-reviewed articles This was actually another difficulty in the sense that I thought until then that to publish an article, you should work in a laboratory, then have some results, and then publish them. I tried to do that. It was not possible in the sense of that at that point for undergraduate students, there was not a possibility to have a compensation for this work, and you needed to stay there at Christmas, Easter holidays, summer holidays. I would need to also let conferences, Erasmus trainings, and so on go, which is something that I didn't do. But then I managed to find a group of people from abroad, a group of people that I have met through conferences or online activities. We wrote our first review and then some letters to the editors and then some book chapters and then many more together. And then the cycle just grew. So after this introduction, which was kind of lengthy, I will just outline some methods that were useful in this journey in the medical school, and I believe that it can be useful to you as well in case you're still studying or you are close to the end of studying. Despite all the involvement in public health, in youth organizations, and so on, I always gave priority on some conventional obligations like exams, decent, not the best marks, but decent marks, and so on. This is necessary so that we can all graduate in time and effectuate the potential that we will have created. I also had to take some decisions. I wanted to live and, study abroad, or at least I wanted to try it. And in Greece, there was either the option of learning a new language, learn German, as I did, to go into Germany or Switzerland, or preparing for the USMLE exams. I chose to learn a new language. Many of my colleagues chose the USMLE exams. Probably one can combine them, and we can only judge the decision at the end. Another advice and method that I followed was that I got early involved in students' associations. And my first experience with the traditional association for medical students was not good. But instead of giving this up, I actually joined some associations that had to do with international relations, public affairs, and so on. And I brought the health perspective there. This worked very well, and this helped me to get network and get involved at the European level in organizations like the Association of European Cancer Leagues, the European Health Parliament, and so on. So don't be afraid to go beyond what is usual. Your perspective is also of added value, and this is something that the world has understood better after COVID, and hopefully even better after COP28 and the joint declaration about health and climate. And of course, something very important here that I believe that you have already realized, since some of you were involved in online research, is developing an online presence, and through that, a network of collaborators, many of whom, in my case, have become friends. The main outcome measures that I will discuss in the results of this trial are training, so clinical pathway, postgraduate studies, and broader social action. In terms of training, I eventually chose orthopedics. For many of us, there is the question whether we should go for surgery or internal medicine. In my case, I was actually inclined into rheumatology, and then a friend who is a neurosurgeon told me that if you want to know a body system, you need to operate it. So for this and for some practical reasons that have to do with the structure of training in Switzerland, I went into orthopedics. Since September 2021, I live in Zurich. It's the biggest city in the country, and I have worked, or I am working, as a research fellow and resident in orthopedics. As a resident, I have been initially in the Balbris Universitätsklinic Clinic. This is the orthopedic special hospital of the University of Zurich, and I'm currently working in the Universitätskinderspital, which is the university children's hospital of the university. And at all this time, I have also been part of the Institute of Biomechanics of Balbris campus, which is a joint project of the ETH Zurich, the Technical University, and the University of Zurich. At the same time, because there is a lot of time, as you understand, I try to do some postgraduate studies. So I studied a distance master in public administration with a focus on healthcare services in Cyprus, where I had this opportunity because of the distance studying model. On this basis, I got a proposal to start a PhD in healthcare management with a focus on trauma and rehabilitation systems in Greece and Switzerland, which I'm doing currently in the Aristotle University of Thessaloniki in Greece. And I'm also preparing or working on a dissertation in pediatric orthopedics in the University of Zurich, which is part of the Swiss pathway of becoming a physician scientist. I also got some interesting involvement and commitment in public health. It was a hobby as a student. I was ambassador of X Health Society in Europe, member of the other student society or the other student parliament. My first award in a conference was about a presentation in public health, but all this actually gathered network, gathered experience, gathered insights that helped me to get involved initially in the civil society space, which is a pillar for public health, at least in the European space. Some of the current commitments are the Institute of Cancer and Crisis in Armenia, the European Health Parliament, where we're producing recommendations for the actual European Parliament, the European Student Think Tank, where we're coordinating a public health and policy working group that was initially an organization for students of international relations and political science, but now we have a very strong health component. The Cancer Prevention Research Group in Greece, Students Against COVID, an organization that we co-founded with Dr. Faisal actually, and the Y20 Youth Summit, which is the youth edition of the G20 Summit. And on this basis, I became qualified, or I had the honor and the privilege to be part of some institutional boards, namely the Horizon Cancer Mission Board of the European Commission. This is an experts committee that advises the European Commission, essentially the European Ministry of Health and Research and Innovation, if I can translate it in a way that you can understand it, on how they can navigate cancer prevention and control in Europe and how they can allocate funding to new research or to problematic aspects of cancer control. We are focusing a lot on pragmatic clinical trials, on living labs, on citizen engagement, so on non-traditional aspects that might have an impact on reducing the rising prevalence of cancer in Europe. And after this is quite new, I also got part of the AVID Action Youth Alcohol Network of the WHO Europe, which is a youth group of activists, clinicians, and health professionals that advise the WHO Europe on how they can improve alcohol control. And all this journey has been accompanied by a lot of writing. Writing has become a good habit. There has been good and bad moments. There have been many rejections. There has been a lot of good and bad feedback, and bad feedback in the sense that there were many people who came to us in the sense of discouraging us. Many people who came to us asking, "Who are you to write? You don't have the right to write. You don't have the right to publish, or you are publishing bullshit," and many other things. So, if you are in writing, develop this as a habit. This is something that I liked before school. I was a poet and a fiction writer, so I'm doing this with happiness. And many of the friends that I have developed are people that we are writing together. But be prepared for criticism and for a lot of questions. And after presenting the results, I will go into a bit of discussion and then wrap up this presentation. The key learnings, comparison with the existing literature or existing practice for young professionals with some self-criticism, and then limitations and future research. The key learnings are that I don't have a lot of time, but in many cases, I'm happy with the sequence of events or with the opportunity to be on 2 or 3 boats at the same time. For instance, a few weeks ago, within less than 10 days, I was initially in Lyon in the agency of the WHO for Cancer Research as part of one of the meetings of the European Commission's board. And then 1 week later, I was in Davos in the AO Trauma Institute doing the practical course on trauma, which is one of the prerequisites of the training in orthopedics in Switzerland. So there is a lot of exchange or simultaneously being in 2 or 3 different boats and at the same time trying to document and write everything. So the key learnings out of this is that it is nice to have a variety of tasks on what you're doing. Of course, a counter argument could be that you cannot be equally dedicated to everything. This is true, but I believe that each one can reinforce each other. Through the involvement in cancer control and particularly in tobacco and alcohol control, which was discussed a lot in the WHO Europe initiative and also in the G20 summit, I learned a lot about susceptibility to fractures, vulnerability to fractures, things that happen every day in orthopedics, things that I notice in my patients, but I wouldn't realize otherwise. And now let's move to some criticism. Some criticism can apply to clinical trajectory. As I mentioned, I'm probably focusing more due to the public health background in operating less rather than operating a lot. So my argument for being involved in alcohol control as an orthopedic who is not by scientific discipline related to this is that this is a main cause of traffic accidents. And many of my colleagues would say, yes, but you should want traffic accidents because otherwise you will not learn to operate. This is an argument, but this is also something that we need to discuss in the medical community. Research trajectory. I'm doing some basic research, the universal clinical research in orthopedic biomechanics, but a lot of research has been quite, let's say, diverted in cancer, in public health, in infections at the beginning, because in order to learn, I was writing with other people, and we were writing depending on the interests of the people and the available projects. So I now have publications in cardiology, in infectious diseases, in global health. This was a big school, but this is something that I can be criticized for. Ideally, one should be able to publish good and deep in one field, but this might not always be the chance. And as long as you can find a connective narrative between all them, I think that this is something that can remain sustainable. Public affairs, all this public health, global surgery, and so on, is how medicine affects the public sphere. And this is where we go outside of the typical role of the doctor that stays into the hospital or into the laboratory and talks only about his profession. Being involved in substance use control, for instance, one has to be critical on media, on industries, on popular practices. For instance, I cannot go out and drink after all this, and many of my colleagues are unhappy about this. So this is something that one should recognize as part of their profession, but also be mindful that it might have to adapt its social routine and reality. And of course, non-professional sphere. I haven't talked a lot about this, and this actually showcases that all these commitments probably don't leave a lot of time. This is something that one should also take into account and try to incorporate within their goals. You don't have to do everything. You have to do what serves you and your purpose, what at first gives you the opportunity to train and earn your living, and what makes you believe that you are really making the best out of your training. All these are options, and many more are still options like consulting, like working in the industry, but you choose what works best for you. Limitations and challenges. I live abroad since 2 years, and integration is a challenge in terms of working and learning in a new language, but also in terms of navigating the dynamics of an international medical graduate in a country that has its own graduates, the graduates of neighboring countries, Germany and France, who already speak the native languages, and then us, people who come from a third, still European country, as a third category of, I would say sometimes foreigners who come to take the jobs from the legitimate owners. This is something that you may face in case you move abroad to work. And this is something that you should expect. But this is also something that you can for sure anticipate and for sure manage. Also the balance between different tasks, groups, and dynamics, especially when you work in different groups. For instance, it's not very common to be a friend with your colleagues in Switzerland. This is because of work-life balance. So they realize that if you have a friendly relationship with a colleague and things don't go well at this pace, then your professional life is also affected. This is an interesting concept of drawing lines, but in most of my other commitments, my collaborators tend to be my friends as well. This happens. And of course, maintaining interest and focus. We can be interested in a lot of things. You all remember from hematology that blood cells start as multi-dynamic stem cells, but we need to grow not only in interest but also in focus. We need to differentiate, not only to multiply. This is something that we should keep in mind. And about the future, well, I will try to maintain this commitment and uh, improve my focus. And something that I would like to highlight to all of you. It is very common in health systems in universities that we are advised not to talk politics and religion. And I use this as big topics that go beyond our very technical professional sphere and might bring us in a difficult situation. I agree that you cannot take a patient and instead of asking him, are you doing today, start talking about the party that won the elections. But our very profession, the way that we practice, we saw that in the pandemic, we are seeing this now with climate change, is affected by the way that policy is practiced. And we cannot really influence and change the lives of people if we don't talk about policies that promote substance use, for instance, or that allow industries to do heavy and unfair advertising. And if we stay silent in this, we are essentially not good even at the technical role that we are expected to play. And I would like here to remind that some of the most well-known doctors definitely didn't heed to this advice and talk a lot about religion and politics in the broader sphere. Hippocrates started scientific medicine by saying that the causes of epilepsy are not metaphysical, they are physical, and we are here to investigate them. Virchow started not only pathological anatomy but also public health in Europe by stating that the causes of a typhoid epidemic are mainly the lack of education and hygiene. And the last figure that you probably don't know as a doctor was actually also a doctor. He wrote a dissertation in syphilis, then he went on vacation. In this vacation, he noticed how the people in Latin America were living and he diverted from his medical career. But all this means that medicine is very much interconnected with the broader sphere, and we cannot practice medicine if we don't acknowledge it and if we don't take appropriate action. A friend recently wrote that if it's Yassir Essar, a very interesting global health activist and professional soon to be, he wrote that you should not write or research on a topic if this has not an impact on policy, not politics, policy, the way that health works for everybody. Instead of conclusions, I would say that all of you should develop a vision. My vision was developing social surgery as a field. So we have global surgery going into a next country and bringing an operation there. We have public health, but we don't have a junction of this. For instance, surgeons talking about alcohol control in order to reduce traffic accidents and polytrauma incidents. This is something that I have envisioned and I'm trying to bring into reality. And this is an example of what you can all bring to the table and what you can support with your advocacy and your progress in the clinical and research field. Make sure that what you do reflects on the broader society so that people will understand you at the end. And before I close, I would acknowledge Dr. Faisal. He is one of the faces in the picture here. It's back in March 2020 when we co-founded Students Against COVID. I believe that Zara is also somewhere in the picture. And at the right part of the slide, you can see an artwork, which is about the person who discovered stem cells. What is important here is that it is painted but by one of your commentees, that we had initially a collaboration about an article that has to do with orthopedics because she's interested in orthopedics. Through this collaboration, I realized that she's also into arts, and she joined our multinational virtual art exhibition for the International Stem Cells Week. So always be creative and always be independent team players. This will take you places. Congratulations to all of you for going through the program. Congratulations for all you learned. Feel free to keep in touch primarily with your mentors who taught you all this translational knowledge, but also feel free to get in touch for questions, especially if you want to know more about Switzerland, Germany, Europe, or anything else that might have caused some interest during this presentation. Thank you very much once more, and all the best in your lives and your careers.
Thank you very much, Dr. Christos. I can definitely speak for many of us here who found something from everything in your presentation, from looking at arts to medicine to surgery to public health. What this made me realize is if we all look back at our journeys, at how we've reached where we are, be it your career span, be it our time as GRRSP program mentors or mentees, we can all look back and create a journey for ourselves. And that's what you've done in a very engaging format of a research presentation. We all enjoyed it, I'm sure, and it's been a pleasure both learning from you and also working together. And I hope some of our alumni will also be joining you in some of these exciting projects moving on in the coming months. So thank you again from everyone at GRRSP. Excellent. We will share Dr. Christos's email for anyone who'd like to stay in touch. In the meantime, Dr. Christos, feel free to stay back if you'd like, knowing your time commitments. We'll be continuing with the GRRSP ceremony for the graduation of the 10th batch of this program, which feels like decades of work that's gone in the background. Before we move on, just a quick introduction. So we've had a very good number of people joining in, some from the previous graduated batches, some who will be joining us later on in January, and of course our stars of the show, which is our alumni from batch 10. I'm Dr. Faisal Nawaz, one of the research faculty members, and joining me is Dr. Rahul Kashyap and Dr. Zara Arshad, who are also research faculties at GRRSP. For the presentation, we will now follow a format where all of our soon-to-be alumni will be presenting their main projects that they've worked on over the last 6 months. And that will be done in the format of 8 minutes for your presentation, followed by 2 minutes of questions by our faculty members. We have already shared the list in the chat of the order of people who will be presenting. But just for now, it will be Eamon who will be sharing her screen and starting the presentation. So whenever you're ready, Eamon, we're ready to hear from you about your presentation.
I'll be just sharing my screen.
Yes.
Can someone please confirm if my screen is visible?
Yes,
yes,
please.
Eamon, we can see your screen.
Okay. Okay, first of all, welcome everyone to the graduation ceremony. And I have worked for 6 months on this project on imposter syndrome exploration among doctors. We have named it WISE-DOC, which is an acronym for World Imposter Syndrome Exploration Among Doctors. So this is just a brief overview of what you're going to talk about in the next 8 minutes. So first of all, I would like to introduce you all to imposterism, which is an internalized feeling of self-doubt and being perceived as a fraud by others. So this was first described by Clance in 1978, and Clance and Ames primarily discovered this among women and those like highly achieving women. So a lot of people, even like those who are not doctors, a lot of us have this internalized feeling of doubt. And there are a lot of research papers already on this topic, but the imposter syndrome among doctors has been less explored. And there was no comprehensive study that was done to analyze the prevalence or the associated factors with imposterism. So this study was started, we started working on it in August, and we launched our study in November. So this is a small chart depicting the imposter syndrome, where Dunning-Kruger effect is like hyping up your abilities. Imposter syndrome is keeping yourself low key. So this is like a brief representation. And the objective of our study was primarily to ascertain the prevalence and the severity of imposter syndrome among healthcare providers. And secondarily, we wanted to explore the association of imposter syndrome with gender, the years of experience as we work in our professional life, the marital status, parental status, and if you are a international graduate, and whether if people are provided any kind of institutional support at their work setup. And the outcome measure used was CLANS IP questionnaire, which is a pre-validated questionnaire developed by CLANS. So we launched this survey, and all over the world, our study participants were primarily doctors, and we had a sample size of 965 with a margin of error of 3%. Our sample size 965, but we approximated it to 1,000 doctors. We, as previously mentioned, we used the CLANS IP questionnaire, and we disseminated our survey via various social media platforms. We hired multiple regional leads via LinkedIn, emails, WhatsApp, and our network. So data collection was done via a Google form, and primarily the study design was an observational cross-sectional study. No intervention was done. So this is the scoring system developed by CLANS, and it was based on a 20 question scale, and all those questions were scored from 1 to 5 on a Likert scale. So if anyone gets a score of less than 40, it denotes that they have few imposter characteristics, whereas a score of more than 80 denotes intense imposterism. So we launched this survey on 23rd of November, and we were able to successfully collect more than 3,000 responses in a period of 15 days. And statistical analysis was done using MS Excel. Our study was IRB exempt. There was no funding received, and there is no declaration of conflict of interest. So coming to the results, our study covered more than 40 countries with more than 3,000 participants. And this is a map depicting the number of responses received from different countries. So coming to the demographics of our participants, our study primarily focused, we were trying to get a balanced response from different sections of the society so that we could be as diverse and as generalizable as possible. However, we found that more number of females responded to our study. And coming to the age group, the maximum participation was observed from people aged between 21 to 35 years. Coming to the marital status, the maximum participation was observed from unmarried people. And coming to the parenthood status, people who were not a parent were majorly our participants. Coming to the designation, maximum participation was observed from residents, interns, house officers. And coming to the specialty, maximum participation was observed from medical fields, including internal medicine, family medicine. So ethnicity, maximum response was from South Asia. And coming to the years of experience of the participants or doctors who were 1 to 2 years experienced, they showed maximum engagement in this study. And so our study also majorly comprised people from urban population. And yeah. So this is like a very succinct form of our outcome that we found. So we found that a lot of 30.7% of the participants had intense imposter characteristics, whereas 23% had few imposter characteristics. This is important since this does not only affect our mental perception, but it also affects our professional behavior and patient outcomes. So this is like a brief chart showing the different categories or the different responses observed across different sections. As we can see here, that female physicians had more frequent imposter syndrome features as compared to male physicians. However, there was not much significant difference found across various age groups or marital status or parenthood status. Coming to the designation, imposter syndrome did not have any significant relation with the designation of the physicians, as we can see that most of them, whether they are an administrator, whether they are an intern, most of them had moderate features of imposterism. Similarly, with years of experience, we can establish a significant association that people who are more experienced tend to have fewer imposter characteristics. Similarly, for specialty, there was not much significant association with the specialty and imposter features. However, we can see a few specialties like obstetrics and gynecology and internal medicine. They tend to have higher imposter syndrome features as compared to other specialties.
1 minute.
Okay, so not much significant association was found with whether you are practicing in the rural setting or an urban setting. And our study had multiple strengths. First of all, due to the increased number of participation, our study was generalizable. Since we collected different demographic features, we can develop a comparative analysis. We had diverse background people, and there's always a potential for future collaboration and work on this topic. However, our study had few limitations. First of all, the cultural, linguistic, and technological limitations, like Google Form cannot operate everywhere. Internet limitation was there. Other than that, there was selection bias and response rate variability. It is possible that the people who responded are significantly different from the people who did not respond, and that could have altered our analysis. So here's a brief conclusion. And so over 30% of the surveyed doctors experienced intense imposter syndrome characteristics, while there was not much significant association with any of the demographic features other than being a female, which was significantly different. And so for call for future action is there, we need to address this imposterism prevalent among all the sections of doctors, and ranging from nearly like interns to attendings. So these are the collaborators who helped me pursue this study, who helped me get responses, statistical analysis, develop the protocol, everything. I am so thankful to all of them for helping me out. So thank you. That was about my presentation. And these are the projects I have collaborated with other of my batchmates from GRRSP10. Thank you so much.
Thank you, Ayman. Well done on your presentation, and also well timed. From my side, just as quick feedback. So in terms of the overall structure of the presentation, I think very nice use of your graphical presentation, some of the slides showing them with the numbers. That was a very nice way to keep the attention as well. And then equally following all the structures of the intro, methods, results, conclusion. That's the basic of what we expect. So good to tick that off as well. The things to improve, hopefully for future presentations, would be in your results section, for example, the table that we could see, there's a lot of data happening in one slide there. So the numbers and the percentages, they sort of joined in together. if there's a way to make that table more concise, maybe the top 5 specialties, top 3 common populations, these are some ways to minimize the crowding on such slides. But other than that, well done. And we look forward to any other feedback from Dr. Kashyap, Dr. Arshad, anything from your side? Okay, all right. Moving forward,
No,
Dr. Arshad.
Zara, and then I have.
Okay, sure.
Right. So very well done, Eamon. This was a very interesting presentation. Only one point to add for a study like this, which may have a lot of results that are actually very significant to discuss. It would be a good idea to have a slide that sums up the key findings of the study. Like for example, the results, 3 slides on the results. Maybe there could be one more which just lists down the 5 or 6 or 4 major key findings of your study so that we remember it forever then. Otherwise, all in all, it was a really good presentation and very well timed, like Dr. Nawaz said, which is always a struggle with cross-sectional studies that we lose on time. So very well done.
I will not repeat what both of them said. I totally agree with them. Only question I have for you, Eamon, is a good job. Only question I have for you is, what is next? So now the data has been collected. Now, what are your next steps?
Now I am planning to perform a statistical analysis, like descriptive analysis has been done, but to establish like whether the results are significant or not, I am planning to perform a more exhaustive analysis of this with the help of some of the collaborators. And yes, so I have started writing on the manuscript of the paper. So I plan to submit it by the end of this year, which may be too much to say, but I'll try my best.
Thank you. Sounds good. All the best.
Thank you. Thank you.
Thank you. Great. So next up, we have our second presentation for this evening from Mariam Asif. So Mariam, whenever you're ready, please share your screen. And we're excited to see your topic. Yes, we can see your screen now. You can make it full screen and we're ready. Mariam, you are on mute.
Can you hear me now?
Yes, perfect. Your 8 minutes start now.
Okay, great. Hello, everyone. My name is Mariam Asif, and I have just completed my graduation in May of 2023 here from Riyadh, Saudi Arabia. And immediately after, I joined a global remote research program. And today I will be bringing to you 2 of my projects that I've worked through the 6 months. And the first one is a hashtag analysis study. And this hashtag analysis study basically analyzes the hashtag heart health and its impact in the Twitter, social media platform X, which was formerly known as Twitter. So let me begin. Okay, so throughout the couple of minutes that I have, I'll be taking you through the background, the methods, the results, and the conclusion. So I think we've often and quite often now have heard that the leading cause of death is a heart attack across the US or across board. But now let me tell you that CDC has informed us that 1 person dies every 33 seconds in the United States from cardiovascular diseases. And the total heart disease cost in the United States is now approximated to be about $239 billion across 1 year from 2018 to 2019. So what is the next step? Now, we have to start taking proactive measures. We have to start engaging our audience, raising awareness campaigns in order to de-escalate the burden of this cardiovascular diseases. I think one of the most important tools to do so would be through social media platforms. And various studies have signified that one of the most impactful social media platform is platform X. And one of the important aspects of that platform is the use of hashtags. And therefore, in this study, we used the hashtag heart health to analyze the global engagement that people have with this hashtag. Now, in terms of hashtag analysis studies, we use the tool, which is called as Fedica, in order to get the data that we're looking for. So we conducted the data analysis from June 1st, 2022 to June 1st of 2023. And what we were looking for is the number of tweets, that were done using the hashtag Heart Health. We wanted to see how much views or impressions these tweets gained, and the geographical distribution, like where were these tweets mainly coming from? Which countries were they coming from? So our primary outcome that we wanted to measure through the study was the outreach that this hashtag was having within the X community and the awareness. And we were going to fulfill these outcomes by measuring the number of tweets and the impressions that we were getting with this hashtag. Now, we have interesting results. One of that being, the first one is that we saw that with the hashtag Heart Health, there were approximately 64,000 posts. And the number of users that were using this hashtag were approximately 27,000 of active users that were using this hashtag. Now, the other thing is that we want to look at the geographical distribution of where these hashtags were really coming from. So the top 5 countries that we saw the most number of posts from was the first one being United States of America, followed by India. Then we had United Kingdoms, then we had Canada, and then we had Australia. In the bottom 10, we had some countries which were usually the low-income countries, which was something like Pakistan, Uganda, and Nigeria. Now, the next question is, we saw the hashtag Heart Health, but what were the co-occurring hashtags that we were seeing rapidly being used by the users? So one, as you can see in the picture, was heart attack, fitness, hashtag vitamins, hashtag yoga. So these were the common co-occurring hashtags that we were seeing in these patients. Another important thing that we analyzed is that the top 10 influencer accounts that was using this hashtag, and we got to know that the leading 10 influencer accounts was 7 Indian media outlets, followed by 1 influencer account from the entertainment industry, followed by 1 account from the sports industry, followed by 1 political figure from Pakistan. Now, what was the theme of these posts that these influencers were actively using, right? So you can see that mostly the themes were around raising awareness about women and their cardiovascular disease, the use of herbal supplements, which is often referred to as Ayurveda, and the accessibility of cardiac care in third world countries. The next result that we were basically analyzing is the activity timeline. Like through the span of 12 months from June 2022 to May 2023, we wanted to see how often and the number of posts people were utilizing, the number of posts they were posting, sorry. So let's say from June 2023 to August 2022, we were seeing that there were approximately 16,000 posts. Following that, in an interval of 3 months, from September to November, there was a drop. And then we saw with the start of the new year, which is 2023, we started seeing an increase in the number of posts with the hashtag Heart Health. This means that there is some kind of attention and awareness being increased using this hashtag Heart Health. In conclusion, we really wanted to analyze from this study how people from different parts or different countries are engaging in this heart health. We wanted to see how influential of a tool this can prove to be. So the more engagement that we see from the people, the more we realize that this can be an important tool to communicate with the people. And of course, we are seeing the diverse set of population that was represented by the number of countries that were involved from the number of posts that they were doing. So that brings me to an end to my hashtag study. And now I'll quickly go through my editorial, which is also based on outreach to the public. Again, something around the public health concept. So what we want to get from this editorial is that we want to promote heart health and taking care of your heart, taking care of cardiovascular and awareness about cardiovascular diseases in the upcoming Summer Olympics in France. I would just briefly go through the main outline we want to take you through this editorial. The first thing is that we want to continuously identify and reiterate the global burden that cardiovascular diseases is having on us. And we also want to study what are the challenges people are facing today in leading the healthy lifestyle. And lastly, we of course want to promote what measures and strategies can we introduce during the Olympics in order for the masses to get be aware of their cardiovascular health.
1 minute.
Yes, and that brings me to the end of my editorial, the second project that I worked on. And these are the researchers that I collaborated on finally, which was a pleasure to do so. And thank you, everyone. And let me know if you have any questions.
Thank you, Mariam. That was very interesting to see, especially for those who are very new to social media research. This was a very nice way to see the heart health study. And then moving to your editorial as well, which is an upcoming work in progress. When it comes to the heart health study, the presentation, I believe, was very nicely structured. You have shown the importance of the topic and then moved through the methodology, which is very important for someone who's new to understand how a study like this was created. My question to you, Mariam, would be that when it comes to limitations for social media research, what are some challenges or obstacles one might come across when it comes to this method?
Okay, I'm not mute. No. Okay, so with social media projects, I think one of the limitations is that if we come to study, for example, would be they might be they might be audio and there might be hashtags that are not being used from the narrative of from spreading awareness. They could be used in other contexts. So including them is one of the limitations that we see. That would be it. Yeah.
All right. Thank you, Mariam. Other than that, of course, all the best with the editorial process, and we look forward to you completing both the papers and submitting it to the journals as well. We'll move to ask any questions from Dr. Arshad and then Dr. Kashyap.
Very well done, Mariam. I loved the presentation thoroughly. I only have one question. How did you ensure that you were keeping confidential the accounts that you used in your study? How did you ensure the privacy of those accounts?
So when it comes to analyzing, so I think with the influencer accounts, we just mentioned the industries that they were coming from. We refrained from using their names or platforms. It would be something that was limited information towards me and my collaborators, and that is it. It wouldn't be included in the final manuscript.
Thank you. That answers it.
Mariam, very well done. Really appreciate your slides and the work you have done in this space. My only question to you is that how you see, because you're using a social media platform which is predominantly talking in one particular language. So there might be opportunities where other languages, other social media platform, like there's a presence, but they don't speak English or they don't tweet and things like that as well. So what would be your mitigation strategy for this manuscript or future projects?
So I think with regards to the limitation of the language, I think when it comes to our manuscript, we can't, that is, of course, one of the restrictions that we have. So I think open to collaborations in different languages. And if we're seeing certain countries that, apart from the US, are on the list in terms of the cardiovascular diseases, I think we have to collaborate with those and engage with those researchers in order to see what the pattern of hashtag and heart health is being used in their countries. I think collaboration would be one mitigation strategy that I can think of right now.
Okay, thank you.
Thank you so much.
Thank you, Mariam. Well done. And this has been a very exciting start to the presentation ceremony. We've looked through cross-sectional study as an example. We've looked through a social media study, touching on the editorial as well. So I'm excited to welcome the next presenter now, which is Auranus. So Auranus, whenever you're ready to share your screen, we are interested to see what you have for us. Perfect. We can see your screen and you can unmute and start for 8 minutes.
Welcome, everyone. So I am Auranus Adi, and I am 2020 graduate, and I just joined GRSP after giving my USMLE exam. So I'm a USMLE aspirant. So my topic was barriers to polio eradication in South Asia, and it was a systematic review. So the background is that although in 2024, the WHO declared the world free of polio virus, but still it remained endemic to South Asian countries, specifically to Afghanistan and Pakistan. So this systematic review we conducted the systematic review to identify those barriers which were barriers for the eradication of polio. So why this topic? So ever since I was in my internship year, I came across this one case of polio, and ever since I felt the need that there should be some research done as to like what are the barriers that are causing the failures. Because ever since the establishment of Global Polio Eradication Initiative, they have vaccinated over 2.5 billion children, and that in 200 countries. But still it remains endemic in Pakistan and in Afghanistan. And there is a big literature gap that I found out through my research, which was that there were global studies that were done regarding the polio eradication and the barrier that identify, but there was no study done that identified the barriers in South Asia specifically. So the methods that we used, so it was, we used a systematic, we did this systematic review by using PubMed as our basic database. And the search term included were barriers, polio, and South Asia. And initially we found 42 articles, and then 21 articles were reviewed by 2 authors. And then eventually we end up with 17 articles that were finalized and were in our review. And then the data extraction was done by 2 principal authors, and our study was exempted from IRB. So because our emphasis is on South Asia, so I wanted to show that the studies that we found, how many we found from a particular region and a country. So as you can see that in Pakistan, we found the highest number of studies, and then followed by India and Afghanistan. So the results were 5 major points, that barriers that we were able to identify. The first was social misconception with the highest percentage, and it included things like anti-vaccine campaigns or lack of awareness in population. Second was religious beliefs with 43%, and it was religious belief towards vaccine, different conspiracy theories, and misconceptions regarding the vaccine. That was followed by politicals, and the political things included war, conflict, instability, and then it was followed by safety issues for polio workers. So it was lack of resources and security concerns. And lastly, the barrier that we identify was vaccine-related issues, which was like unavailability of cold chains and area with limited resources. So these were our percentages. As you can see that social misconception holds the first place, followed by religious belief, and then by safety issues of polio workers, and then the unavailability of cold chains or vaccine-related issues, and then resistance to polio strains. So in my conclusion, the 5 points that we concluded from studying all these studies were, and how can we overcome those barriers, was like systems like CBMIS, community-based monitoring and information system, can not only improve vaccination, but they can also provide us insight in how to modify the social and behavioral factors so that the barriers can be overcome. And secondly, it was that governments need to apply stricter strategies to identify those barriers and deal with the challenges. And the third was the collaborative efforts with different governments and different NGOs and different countries can really help with the overcoming for those barriers. And then the lessons which were learned from the previous community engagements and from the previous campaigns, that we can amplify them and then apply on the recent campaigns. And then a political approach towards the vaccine-related issues will significantly increase the success level of polio anti-polio campaigns. So that was my main systematic review. We started another review, which was mycoplasma pneumoniae, and it's still under the process of manuscripting. And we basically started this after learning by this recent endemic from China, and we are trying to investigate the clinical pathway and relate it, and just provide our valuable insight towards the current studies that are already available. So at the end of my presentation, I would like to highlight the collaborations that I have done, and thank you everyone for making me part of your team. And yeah, I would just say that it's the time to end polio. Thank you so much, and let me know if you have any questions.
Thank you, Aranus. Well done on your presentation, and of course, your active involvement throughout the program and in collaborating with other projects as well. When it comes to the systematic review on barriers to polio uptake and vaccination, I think the topic on its own, the choice of topic is very important, and you've done a good job in picking that. Feedback on what can be improved for this presentation. So starting with just the basic things when it comes to any errors during presentation with, typing, good to have that reviewed as many times. The other part would be with the results. So when presenting the results, if we can have more details about the population. So you've mentioned the countries, which is great, but how many people overall were involved in your systematic review in terms of the participants? What were their demographics? That would be interesting to know before we move to barriers. Other than that, the conclusion was another feedback point where hopefully the conclusion is the conclusion of the study. So we try to sort of summarize what happened in the study, and then that is the conclusion. What you had was very important, but that goes under recommendations, which is good as a recommendation slide. So good to keep that in mind for future presentations, but very happy to see such a promising project in the making. And of course, the mycoplasma review, we look forward to you building on that and then hopefully sharing your review update with us in the coming weeks.
Thank you,
Dr. Most welcome. I'll move forward to Dr. Arshad's feedback and then Dr. Kashyap.
Very well done, Aranus. This was a very good presentation. And also because it was a very pertinent topic to discuss. I have 2 points to add as feedback, and I believe 1 question. Firstly, that your presentation lacked a little bit of figures and graphs, I believe. It could have been more visual for me to remember it. That's one thing. The other was is just a repercussion of what Professor said. There were some errors in the text, specifically with spellings on some slides, that when you see on a presentation being given, it actually puts in a bad eye. So it's always good to review as many times as possible. The question that I would like to ask is, number 1, what were the challenges you faced when you were making your search criteria or the keywords you were finding out for this topic? Because polio for most of the world has ended, and I believe the literature has now gone back a lot of years. So that is one thing. The second thing is that I would like to have a little more clarity on the methods as well. Where you start, it's the same when you explain how what keywords you used and how you were able to reach on that. Also expand on what you did with those keywords and how and when you went to Rayan, what you did from that point onwards. That clarity was not given on the method slide.
Oh, thank you, and that's a very good question, Dr. Zara. So with my search criteria, primarily I had very difficulties with finding articles because, as you said, that polio has been eradicated from most of the countries in the world. So it was very hard for me to find the articles, and then the articles were not specific to South Asia. So that was one of the things that we faced. And then about the second questions that you asked about Ryan. So first of all, we had like 42 articles, and then we extracted them to Ryan, and then 3 of our authors, principal authors, we double checked it, and then we had 21 articles that we wanted to include, but we were not able to extract 3 articles, full articles. That's why we in our final review we included 17 articles.
That answers it. Thank you, Aranus.
Thank you.
Thank you, Arnuj. I agree with the Faisal and Zara's comments. Only thing I would say is that I really loved the conclusion with your putting together those subheadings of barriers. I think you can do a lot of wonders with that in your manuscript. So I would definitely like to see your manuscript in these subheadings, what you're putting it together. I think it's important for the world to know, because we are just one disaster, one pandemic away for some of these eradicated disease to come back. So that is a very important work. So congratulations and kudos.
Thank you so much.
Okay, well done, Arunus. And that is bringing us to the next part of the presentations. And of course, those who have presented already, I'm sure there's a bit of relief. The questions that are asked are exactly what you would see in conferences, panel discussions. So you're all actually getting an exposure to that as well. Moving on to our next presenter is Rupali. So Rupali, whenever you are ready, we will have you present. 8 minutes. And we see your screen. You can move it to full screen and begin.
Is it visible now?
Yes.
Okay, so good afternoon, everyone. Sorry for the bad voice. I'm Dr. Rupali Dahiya. I joined the GRRSP batch 10 in July 2023, when I was done with my internal medicine residency back in India, and I was coming to US to gain the US clinical experience in my journey. So being a first generation physician, this medical journey has been so wonderful, where I was exploring the different fields of medicine, and now the time has come that I'm exploring the field of research. So this was a very first exposure for me to gain insight into how research works. So this is how I depict like an empty canvas and so many color pencils lying to paint this canvas and to bring a masterpiece forward. So coming to the projects that I was working on, so there were two main projects that I was working, and there were several where I was collaborating. So the first one amongst them is the diverging from the mainstream, a systematic review on varied atypical presentations of acute aortic dissection. So as we all know, aortic dissection is a ticking time bomb, and most of the times in patients, they don't come with the typical presentation of severe chest pain radiating to back, and we miss those patients and on autopsy, and sometimes we don't even get to know that the diagnosis was aortic dissection. So this topic is really important, and that was the main focus that I wanted. That's why I wanted to do this systematic review. So these were my collaborators, and I'm glad to tell that it's registered under Prospero at present. So the basic background, that it's a rare and challenging catastrophic emergency. You'll be amazed that it was first described 2 centuries ago. Until now, we are experiencing the new presentations of the disease, and it's still giving us surprises in day-to-day clinical practice. So it's crucial for a clinician to be cognizant of these atypical presentations so they can diagnose the condition early and do the needful as early as possible. So this was a systematic review with the inclusion criteria of people of any age or gender who had atypical presentation. We included case reports and case series in the last 10 years. And the articles were written in English or any language where the abstract was in English were included. The exclusion criteria was the typical presentation of aortic dissection, or if the patients had isolated artery dissections like renal artery dissection or celiac artery dissections without the presence of aortic dissections, those were excluded. Then the abstract or articles where the full text was not available, or there was no great description of the presentation of the case, or those articles were shared in other publications, so we didn't include them. So as per the any systematic review, there's these 4 bullet points that we need to go through. First is the database search. So in our case, we went through PubMed and Scopus, from where we got the majority data. And the highlighted one is the search criteria that we used to get the articles. And the second step is to screen the title and abstract on a software called Ryan. So this was my first experience with Ryan, and it has been great. Then the third step is the data extraction in a Microsoft Excel sheet. And then the last step is data analysis. In my case, it was basically doing the simple calculations in terms of frequency, percentage, and proportion. So this is a Prisma diagram which shows that we have the two databases, we remove the duplicate records, we screened the 127 articles on Ryan, out of which 49 were excluded, and ultimately we had 78 articles, out of which for five articles full text was not available, and one of the article was not in English, so that was excluded. So in total we had 70 case reports and 2 case series to work on. Just to give an overview how the tables look after we extract the data from the Microsoft Excel sheet. So I had 3 tables in my study. First, showing the patient characteristics, basically the paper first author, the year of publication, and the age, sex, blood pressure, pulse rate, oxygen saturation, pulse asymmetry, murmur, or the dissection type. So this was the first table. And the second was the varied presentations that the patients presented with. So I have included 11 symptoms and an additional miscellaneous category. So this was a very long table, so I've just taken a screenshot to give you an overview. And the third one was how the patient was evaluated and what was the final outcome of the patient. So this way we got to see what diagnostic modality was utilized to diagnose aortic dissection and what ultimately happened with that patient. So coming to the results section, as I told, there were 75 patients that we looked into. The majority, as in most of the reviews, was the male population with the mean age of 51 years, ranging from 12 to 89. Amongst the presenting symptoms, atypical chest pain was most common, which was seen in 36% patients, followed by focal neurological deficit, followed by dyspnea, acute abdomen, altered sensorium, vomiting, dizziness, backache, syncope, fever, dysphagia, and hematuria. Yes, so dysphagia and hematuria, they can be the initial presentations of aortic dissection, so one need to be really careful with them. Then type A aortic dissection was most prevalent than type B. It was seen in 82% patients, and it had a pretty high mortality. Among the comorbidities associated, hypertension was the most common, seen in 36%, followed by dyslipidemia, followed by prior aortic diseases, COPD, heart failure, diabetes, and CKD. So for the amongst the diagnostic modalities that we had, CT by far is the most efficient one, but the bedside echo is also one of the options that we can use if the CT is not available, and we can get to the diagnosis as fast as possible in the emergency settings. As we all say, there's always role of addictions in the pathogenesis of aortic dissection. So in our case also, we found that smoking was the most common addiction that we found in most of the cases, followed by alcohol, cocaine, synephrine, ecstasy, and amphetamines. So conclusion, we were able to summarize the clinical characteristics, the presentation of the patients, and the treatment which was offered to the aortic dissection patients. It's really crucial for clinicians to be cognizant of these clinical manifestations, to consider it as a differential diagnosis whenever they are sitting in emergency or dealing with day-to-day clinical cases. Now, coming to the second topic, this was a very short review that me and my team finished in 3 days. So yes, it was an amazing opportunity where because of the death of the famous actor of Friends, Chandler, Matthew Perry. So after his death, we got to know that the hot tub bath can lead to tragic consequences, and we wanted to look like how the hot tub bath, which is a very contemporary style thing in the current scenario, can have detrimental effect on somebody who has predisposing conditions or has alcohol abuse or has some mental health conditions. So this was a short review where we focused on each and every of this thing. And this was a pictorial diagram that we sketched to show the potential causes contributing to hot tub deaths. And we could very well illustrate what is the pathophysiology of the deaths in hot tub. And we could also put the mitigation strategies to deal with this public health issue. So this was my second project, which I submitted to the GRRSP portal in the GRRSP. Next, the collaborations. So I'm really thankful to all my batchmates to give me an opportunity to work with them. So I worked with Amna on her beta thalassemia and autoimmune disease project, and another project on side effects on hematopoietic stem cell transplant in children. Then I also worked with Sharanya on the causative role of infections in development of sarcoidosis, and two famous global surveys, the Impact F and Talk survey. And I'm also looking forward to work with Mariam on her hashtag analysis. And we have 3 more projects in pipeline to work on, and I'm looking forward for more collaboration in future. So this is how you can contact me. I'm active on LinkedIn, email, and Twitter. And just the last slide of a big thank you to all my batchmates who have worked really hard to collaborate and to give me insight how the research works in collaboration. And the second image is basically how our mentors have guided us to get through the end of the project, to get to realize how the research works, how the reviews work. So this is Dr. Zara, Dr. Faisal, and Dr. Kashyap pulling us up to match a level where we can work in the world of research. So thank you, everyone.
Well done, Rupali. Congrats on such a comprehensive presentation of both your projects. I can already see shower of comments that you can probably read on after the feedback, but really good to see that. And just going through the feedback now for your systematic review on aortic dissection, I think it's a very well-rounded presentation because it had a good mix of introducing the topic well in simple terms, which helps others understand the background. And then you've moved on to include a nice Prisma chart. And then you've defined how your methodology was, which makes everyone clear that, yes, you've used the right research methodology to go through such a project. My point to improve for you would be when it comes to any slides or results specifically that are a bit too much to share, let's try to break them down into 2 slides instead of keeping it in one. So that would help read a bit better as well when we're looking through it. And then the color theme as well, that's something just aesthetically where if we can look at colors that are more blending in with the background, so that could help as well. So these are common poster presentation, oral presentation guidelines. My question to you would be more on just the basics of a study design here. So when you had the topic of aortic dissection, what was your thought process into picking that, yes, this should be a systematic review project? There could have been a cross-sectional study on it, an editorial on it. So why systematic review?
So first of all, systematic review, meta-analysis, these are big terms that I heard when I entered into GRRSP. So I was really interested in doing this thing. And then when I searched through the literature, there were so many small reviews, or there were the observational, there were few observational studies which were already there in literature in different aspects of aortic dissection. So this gave me an opportunity to see how a systematic review of case reports and case series could get me to learn about how the different presentations can affect the outcome of the aortic dissection patients. So this is something that was lacking in the literature in last 10 years. There was no comprehensive review just focusing on the presentations. So I thought this was a stride for me to take. Here I am.
Well done. Thank you. Moving
Thank
to feedback from Dr. Arshad and then Dr. Kashyap.
No questions from me. Thank you, Professor. Very well
Same
done.
here.
everyone.
Same here. Very well done.
Well done. Great. All right. So we are at the midway point through the presentations, and it's been a very impressive, positively competitive quality of presentations here. So let's hope the consistency stays on for our next presenter. So our next presenter is Sumaya Faisal, who is ready to present, and I'm just as excited to see what she has for us. So whenever you are ready, you can share your screen and you will have 8 minutes to present. Yes, we can see your screen now and you can start.
Hello, dear mentors. Hello, dear mentors, past and present alumni of GRRSP and my dear batchmates. I have put my heart and soul into this project, and this project means a lot to me. So presenting the research titled Impact F, which stands for Influence of Marital Pressures and Cultural Constructs on Females, a global study of medical students and physicians. Firstly, let's start with a brief background. Why did we think that there was a need for such a study? The average age for females getting married worldwide is 18 to 28 years old, while the average age for attaining medical education and becoming an early career physician is between 20 to 30 years old. As you can see, there is an overlap between these two age ranges. Impact F study wanted to address this overlap in which female medical students not only have to deal with their rigorous medical career, but also have to deal with their marital responsibilities and work-life balance all at the same time. When we did a literature research, the gap we found was there wasn't much published literature talking about marriage affecting medical education, or rather, the literature only talked about work-life balance after marriage. So, in order to bridge this gap in literature, we developed this survey, and we want to bring some changes in the society through this survey. And this was the short background. So, taking you through the methods quickly. This is an observational cross-sectional study, which is conducted using an online survey created using Google Forms. The survey was anonymized and it was a self-reported questionnaire. The language was in English, and our target responders were medical students and physicians of all genders and sexual orientations. The study's data collection began on the 24th of November 2023 and lasted until 15th of December. And it has, the questions were 34 in number, and then we had 5 sections that were 5 distinct sections. The number of responses that we garnered in these 22 days were 3,020. And we received IRB exemption from Mayo Clinic. Okay, so this is the recipe of how we cook a research survey. First of all, we looked for a questionnaire, the perfect questionnaire. And after ravaging the internet looking for articles related to our topic, we were not able to find a questionnaire that we were looking for. So we prepared a questionnaire from scratch. In our questionnaire, we decided to ask questions which were answered in a 5-point Likert scale. And after deciding on the questionnaire and literally sitting over it for over a month with our teammates and mentors, we sent it for external validation to experts in the field. And also, we ran a pilot study. We ran a pilot for the questionnaire, and our Cronbach alpha score was 0.894. And for okay, we had the questionnaire ready, but we had to reach it across the world. So how would we do it? We followed a hub and spoke model. And gradually, from one country, starting from India to Pakistan, we spread it across 52 countries. So coming to the results, as you can see the world map displayed, in a matter of 22 days, the Impact F team was able to get 3,020 responses from 52 countries. And obviously, India was ranking the list with 12.38% of the responses, followed by Egypt and Ethiopia. The respondents were mainly female, but we had male respondents too. And that's not a small number. It was 997 out of 3,020 respondents. Most of the respondents were unmarried, while 601 of them were married. Okay, so, and we saw that most of our respondents were medical students, and mainly the respondents were either Asians or Africans. Among okay, so now let me take you through the results. Our first section was about perceptions and attitudes and experiences and practices. We kept our questions such that even people who did not identify themselves as females could answer to these questions. So we found that 45.76% believed that the societal pressure for marriage differed for male and female physicians. And almost half believed that it actually affected the mental health of female medical students and physicians. Whereas, well, again, almost half of them believed that societal pressure for marriage was actually responsible or in some way shaped the career trajectories of female medical students and physicians. And we had our respondents answer to a question in which they could choose any three factors which they thought were contributing towards the societal pressures. Topping the list was traditional gender roles and cultural beliefs. Second in that list was family expectations. And third was societal perception of age of marriage and having children. The section B was with regards to career progression and marriage. We found that about 35.56% believed that female doctors or female medical students needed to marry or were expected to marry at an age younger when compared to their male counterparts. And they almost 34% believed that female medical students and physicians chose to work part-time in order to juggle between their career and their families. And 31% believe that female medical students were expected to prioritize having children over their careers.
1 minute.
So here we look at how it affected the mental health of the female medical students and physicians. Almost 50% was stressed from juggling career and marital commitments. And almost half were worried that dealing marriage could negatively impact their personal life. And burnout was experienced by almost 44.9% of the responders. This section deals with their coping strategies. The first one, out of the respondents, 46% strongly believe that having an open communication with their spouse or partner was the best way to deal with this problem. Apart from that, working in flexible hours and setting up a support system followed next. So I would like to say that in summary, the impact of societal expectations and cultural pressures on women, especially in the medical field, is a complex issue affecting mental health and career paths. Addressing this, the gender disparity and the pressure to get married that starts early on in the female physicians or female medical students' career makes them take decisions which they would have otherwise not taken. Our effort is to provide a supportive environment so that we can promote the well-being and success of female medical professionals so that it would benefit not only their careers, but also their personal life. Thank you. And thank you, dear mentors, for always being there for us with always responding to my innumerable questions. And I would like to dedicate this presentation to the team that made this possible. This is our team. Thank you so much.
Thank you so much, Ume. It was a great presentation. First off, I really appreciate the fact that you were able to take up this topic, make a good questionnaire out of it, and do this whole study, because that was the most trickiest part to this study. So kudos to you for all the struggle that you've been through before you even started doing this. Some points for feedback. You were really good with the way you introduced the topic and the background. It was beautifully laid, so I really loved that. That's one thing. The presentation was good. However, on most of the slides, there's a lot of text material to absorb. And if there's not a lot of text material on some slide, there's a lot of pictures to absorb. So you need to make a good balance of how many bullet points you're adding as text and then how much of images you're adding. Visual content is always good, but a lot of visual content as well is a problem on the slides. So you go lost in what to take from the slide. So my suggestion would be to always stick to the 5 or 6 major points of that one long paragraph you're putting on a slide. That's one thing. The second thing would be the conclusion. Again, because this is a very important topic and we know we are able to find out very important things, we were not able to see that on the conclusion slides, a slide in terms of bullets. So I remember a paragraph on the conclusion slide, but not bullets. So those would be 2 things. And that's about it. Very well done, Ume. Thank you for your presentation.
Thank you, Dr. Zara. I'll keep everything in mind.
All right. And with this, we should be moving on to the next presenter, who is Ahmed Yar. Ahmed Yar, are you ready?
Yes, I'll just share my screen.
Perfect. As soon as you share, your 8 minutes will start.
Okay.
I can see your screen.
Okay, great. Okay. Hello, everyone. So my name is Ahmed, and over the course of these 6 months, I worked on 2 research projects of my own, as well as collaborating with others. So I'm going to discuss both. Because I'm going to try and discuss both, I will be a little bit brief on each, but hopefully I can provide enough information to give you a solid idea of what I've been doing. So the first topic I wanted to discuss was ChatGPT and neurology. This was basically a original research article which looked at the impact artificial intelligence can have in different medical applications. So in recent years, AI has been growing in popularity in the medical field as well as the non-medical field. In the medical field, there has been work conducted in certain disciplines such as radiology, dermatology, even certain surgical fields. However, neurology was an area untapped at this point. my personal interests are in neurology, so I thought this would be a good opportunity to see how useful ChatGPT at this point in time could be in clinical neurology. How we went about doing this was because it was an untapped field, we wanted to touch base with the most common neurology scenarios. So through a system of trial and error attempts, we curated 3 of the most common neurology presentations, one being in a stroke case, one being in a headache case, and one being in a dementia case. We then started a list of prompts using ChatGPT 3.5, and we were then assessing how ChatGPT would respond to these prompts. So as you can see in the methods section, I've detailed how in the first prompt output, we would look for the most likely diagnosis, the differentials, and the workup plan of that condition, of that presentation, sorry. And then in the second prompt, we would use the same presentation and we would look for the most appropriate management plan. We then had this data featuring diagnosis, differentials, management plan, and we provided this data to an expert neurologist in order for her to evaluate the generated responses and to determine not just how accurate the responses are, but how useful is this information? How useful is the presentation of this information, the layout, etc. So the actual results section in my manuscript covers around 15 pages. Presenting all of that right now isn't feasible. But what I've tried to do is give you a brief kind of indication of how things look. So as you can see on the first image I've shared, you have the headache condition, you have the prompt, which is the presentation, a classic kind of presentation with chief complaint, history of presenting illness, family history, etc. And then asking for the diagnosis, differentials, and workup. And then you see the beginning of the output from ChatGPT, and it continues for 1 to 2 pages. You then have a management, which is the second section of the prompt, where you have the presentation, confirmation of the diagnosis, and then provide a comprehensive management plan. This is for the stroke condition on the right-hand side. And then you have another output from ChatGPT, again, spanning around 1 to 2 pages, with a very detailed description of steps to take in the management of this patient. So in terms of the feedback we received from the expert neurologist, it was concluded that, yeah, the results are generally quite accurate. The software did demonstrate good clinical knowledge when it comes to identifying the disease from the classic presentation. One thing noted by the expert neurologist that kept showing up was the vagueness in the responses and the generalized, each answer was around 1 to 2 pages, but sometimes it could have been half a page. But ChatGPT tended to just give you all the information it had, and hopefully the actual answer is included in that 1 to 2 pages. So there wasn't really a tailored approach at this point. And then also there were some current guidelines, especially for stroke management, which weren't quite updated in the output received from ChatGPT. So we do see significant potential at this point. Clearly, there is good accuracy in general. However, there is a lot of work to do, especially in a field like neurology, where there are certain disciplines, especially stroke management, for example, where guidelines are constantly changing. ChatGPT acquires its knowledge from a public domain. So guidelines are usually restrained to like private sources of articles that can only be accessed through journals where you need to be subscribed to, etc. So there are these challenges, but I think in future, just further exploration is warranted to address these challenges. And also further work is needed to take a look at whether or not statistical analyses can be conducted to actually get a more quantifiable outcome as to how effective ChatGPT is. At this point in time, this paper has been written, the manuscript has been written, and it's under external review. Moving on to the Neuro Twitter paper. So this is a hashtag analysis study similar to what Dr. Mariam did. Similar to the AI paper, social media analysis is a recently growing field where different disciplines are being looked at in the field of how that community is discussing the topics. So one of our mentors, Dr. Faisal, recently conducted a hashtag analysis study on Psych Twitter, where everything related to psychiatry was kind of discussed and taken into account, and then those findings were then discussed relative to other similar hashtag analysis studies that were conducted at that time. Likewise, for me, given my interest in neurology, I wanted to take a closer look at neurology, and I wanted to see whether Neuro Twitter could give me an insight into that community related to not just neurology, but also neurosurgery, also neuroscience. How we conducted this was similar to Dr. Mariam's study. We used the Fedica software to characterize tweets containing hashtag NeuroTwitter. The timeline we used was basically 1st of June 2022 to 1st of June 2023. So it was a 12-month study. Once we received the results, this was the actual results and analysis of the results was conducted by an external doctor named Dr. Atanasov, who's an expert in this field. And then these findings were then presented to us, the GRRSP team, in an Excel format for us to then make graphs on and fully analyze and decide how we're going to create a manuscript from this. So what we get from this NeuroTwitter paper is a number of things. You know, initially, I think a good place to start is just what's the popularity, what's the general outlook like. So there were a total of 216,558 posts in the span of 1 year, shared by more than 61,000 users. So straight from the beginning, you can see that this is a pretty popular topic, and it has a large reach. In terms of who contributed the most in this field, unsurprisingly, the three most common groups of contributors were healthcare related, students, and education related stakeholders. Neuro related topics tend to be more of a academic, tend to provide more of an academic discourse compared to even other medical specialties. So that was no surprise there. And then also the top 3 countries was not too surprising, because the United States, of course, with neuro-related topics being so academically oriented, the United States has the most funding for such research projects, etc. So it being the country where the most posts are contained is again of no surprise. I've shared 2 figures on the right-hand side. The first one shows the reach distribution, basically just how many posts reach how many people based on how many followers the person who posted that has. As you can see, neuro-related topics are typically distributed by people who have a mid-range of followers. And then the graph underneath illustrates the activity timeline. So this showcases when during the course of this past year, June 2022 to June 2023, can you see more activity, less activity related to NeuroTwitter? The peak time.
Sorry to interrupt the conclusion, and then we'll conclude. If you can add your conclusion statement, please.
Okay. So yeah, so my conclusion for this is just that it marks the first exploration of hashtag NeuroTwitter, and this is a wide platform, so further research would be good within subtopics of neurology. And these are the collaborations that I've worked on throughout my time in these 6 months. And thank you very much. Any questions?
Ahmed, you did a fantastic job. There's something you can unshare your screen. There's something to your soothing voice that any project look good in that voice. But regardless, I think you've taken very tough topics, and then what you're able to do with the large language model is commendable. Really, really good job. Only comment is that some of the slide where you're showing the screenshots of the ChatGPT command or part of it could use bigger space. If you have a little bit of that space there, you can utilize it. Otherwise, I could not find much flaws in your presentation. Job well done.
Thank you.
Congratulations. Thanks.
All right, that brings us to our final two presenters. And of course, we're just as excited to hear from you. So we'll go ahead with Amna. Amna Hashmi, once you are ready, please present and we'll start your 8-minute timer.
Hello, everybody. Can you all see my screen? Can you all?
Yes, we can see your screen.
Okay, perfect. All right, is this good? Oh, no. Okay, so my name's Amna Hashmi. I graduated from University of Debrecen in Hungary, and today I'm going to be presenting two of my projects. So the first one is connecting the genetic dots, investigating the link between beta thalassemia and autoimmune diseases, a systematic review of case reports. So, Okay, so beta thalassemia is marked by insufficient beta globin production. It results in severe anemia and many complications. But many times, patients are diagnosed with diseases later on in life that don't seem to even connect to beta thalassemia at all. Now, recent research indicates a potential association of beta thalassemia with autoimmune diseases, but the precise reason for this link still remains unclear. Could it be genetic? So, is there a link to the beta globin locus's proximity to immune genes? We don't know. Despite many publications nowadays, a systematic review focusing exclusively on case reports is lacking. My aim was to examine the association between beta thalassemia major and autoimmune disorders and assessing case reports and case series involving both. Now, exploring the role of beta globin genes' proximity to immune-related genes in cases was also another aim of mine, but it was secondary. Now, for methods, the study design was a systematic review of case reports. An electronic search of PubMed database was done. Our inclusion criteria and exclusion criteria are as follows. So I'm just going to be focusing on the inclusion criteria. We focused on case reports, case series, and participants of any age, any gender, diagnosed with both beta thalassemia, major, minor, intermediate, and sickle beta were included, and at least one noted autoimmune disease. So language, of course, we chose English, and full article and abstract both should be published in English. The search criteria we used was as follows. So beta thalassemia or beta globin gene and autoimmunity or immunity genes. And we put that into the PubMed database. The Prisma flow diagram that came about with the after searching was here. So we got 50 articles from PubMed. Duplicates were removed, but I had 0. Screened, and we excluded 27 articles. The reports that were not retrieved were 4, so that got us with 19. And of course, the included articles rounded up to a total of 13. 50 articles exported to Ryan Software. So 6 authors, my co-authors, each study, 6 authors reviewed all of them on the Ryan Software, and we were able to retrieve total of 13 reports and 12 case reports and 1 case series. We then participated in data extraction into a Microsoft Excel Word spreadsheet, and The study was exempt from IRB approval and registered on Prospero. So here is an example of the patient demographic data extraction that we had. This is just the top 5 cases. Sorry, top 5 patients that we could see. Of course, we had 19, but that was too much to put on one slide. As results for patient demographics, a total of 19 patients, 11 of them were female, 8 of them were male. Ages range from around 8 months to 35 years, majority of them falling below 16 years of age. Beta thalassemia, as you can see here in this pie chart, 65% were major, 25% were minor, and of course 10% sickle beta. As referring to autoimmune diseases, we had majority of the cases that we saw were autoimmune hemolytic anemia, or that were around 71%, and the rest were systemic lupus erythematosus, Hashimoto's, Crohn's, rheumatoid arthritis. Of course, these were the most prevalent. Ethnicities, there are around majority were Asian, so Chinese and Indian, and the rest were African, and around 11% unknown. Clinical presentation was the next thing that we extracted. Again, this is the top 5 cases. For the results of clinical presentation, the majority of the symptoms and signs our patients witnessed were anemia, jaundice, hepatosplenomegaly, tea-colored urine, and the rest were abdominal pain, fever, cough, and chest pain. The rest were not so significant.
1 minute.
Our next was for laboratory findings. This is just this is just a basic depiction of the lab findings that we saw. The next was management and outcomes. And as we can see here, I've depicted. The conclusion. So our findings strongly supported a correlation between beta thalassemia and autoimmune disease. It's important because crucial implications for clinical practice. Now, clinicians should be vigilant of the development of autoimmune disease in beta thalassemia patients to avoid fatalities and, of course, comorbidities. Now, identifying specific risk factors and early signs of autoimmune diseases can enable targeted therapy for a better quality of life. Now, in the future, a large-scale cohort study would be advisable, and that's what we're going to look at. Now, my second project is a comprehensive analysis of the novel side effects of stem cell transplant in children, a systematic review of case reports. As a background, so a large portion of recent advancements in stem cell transplant for children is very prevalent nowadays. Now, stem cell transplant, as you can imagine, has many side effects, but the current literature doesn't predominate around the uncommon ones. And there's a need to comprehensively understand these uncommon side effects associated with the transplant. Our aim was to delve into the uncommon or novel side effects of childhood stem cell transplants, providing a thorough analysis through a systematic review of case reports. The study design was of course, I've said it many times now, systematic review of case reports. Our inclusion criteria was as follows. So case reports and case series, individuals who underwent childhood stem cell transplants. So the age was less than 18 years of age, with experience, documented, and clinically relevant side effects or complications, language in English. And this was our search criteria that we filled into PubMed database. We exported 70 articles into Ryan. 5 authors had reviewed all of these articles. Total of 32 reports were included in the systematic review, among which 18 were case reports, and 14 were case series. All 5 authors were then working in the data extraction process into Microsoft Excel, and currently still in the process of finalizing results and manuscript writing, so stay tuned. My collaborations were all of these following projects with Rupali, Ayman, Aranus, Ahmed Yar, Mariam, and Sharanya. And that would conclude my presentation. Thank you so much for listening, and I'm so sorry for going above the time limit. I'm so sorry for the grammatical errors as well. That's it.
Thank you very much, Amna. Very well done. We're actually very proud to see your progress across both projects, and the comments in this chat are also speaking for the same, which means our collaborators and those who you've worked with have also felt the same about you. So well done again. Just about the systematic review project. So looking at beta thalassemia, I think a systematic review of case reports on a genetically linked disease as such is not common to have. So my question to you would be that in terms of the gap in your literature, is there anything that led you to creating a case report-based systematic review?
Sorry, the question, could you rephrase that? I didn't quite understand.
Yes, in terms of the gap in the literature, when you were looking at choosing your study design, was there anything that made you pick case reports as your systematic review topic?
Mm-hmm. So I chose to focus on case reports exactly because I was searching on PubMed before that, and everything was it was just, what's the term? Not descriptive. Everything was just descriptive. It was all like up in the air, informative, and nothing was with evidence. And I wanted to focus on evidence more than just the genetics. And I wanted to see that was there actually a correlation or not? And this would actually lead me to my next project. I hope to do maybe like a meta-analysis and, be able to compare with a control group like normal patients with no beta thalassemia and see the prevalence of autoimmune disease. So I thought maybe I should start with case reports. I should see if there even is an association and then go from there and hopefully.
Perfect. Thank you very much, Amna. Very well answered. And we look forward to future projects as well. Great. Looking at our final presenter, and that brings in just as much quality and hard work over the last 6 months, is Sharanya. So Sharanya, we're very happy to have you present. And of course, the stage is yours for the next 8 minutes, whenever you're ready.
Can you hear me?
Yes, and your screen is visible. You can go full screen and start presenting.
Perfect. Hi, I'm Sharanya, and since I'm the last presentation, I'll try to make this as painless as possible. So this is my topic. I'm doing a systematic review on exploring the role of infectious triggers in the causation of sarcoidosis. The background of this study, sarcoidosis has always garnered a lot of interest in the field of research because of its complex pathogenesis. There are multiple factors in play. Mainly, there is some external factor, an antigen, that could be an infection, it could be some kind of an environmental factor. This triggers a disorganized or disproportionate immune reaction in somebody who's susceptible with some kind of genetic factors. So we are dealing right now, we are going to be focusing on the microbial organisms which has been implicated as a trigger in those with genetic predisposition. However, all the studies so far have been largely inconclusive. So that is the reason why this was a topic that I wanted to go delve into. The last meta-analysis of this was done in 2015, and this dealt with case control studies from 1985 to 2015. And they did show an association between sarcoidosis and infections like Mycobacterium tuberculosis, Propionibacterium acne, and Borrelia burgdorferi. However, I was interested in seeing if any patient who had COVID virus infections developed sarcoidosis later on, because there were some case reports being published. So the methodology was to study the association between infectious agents and the development of pulmonary sarcoidosis. I focused on pulmonary sarcoidosis in order to make it more specific and easier for analysis. The study design, it was a systematic review of case reports and series. It was IRB exempt. The inclusion criteria, we included all case reports or case series from the duration of 2015 to 2023, since the last meta-analysis also included case reports then. The prerequisite for inclusion was a diagnosis of pulmonary sarcoidosis, either confirmed by clinical or histopathological criteria as per the ATS guidelines. And the infectious agent should be identified either by cultural or molecular methods. It is not just a clinical diagnosis. And the important thing was we had a temporal association where the infectious pathology should be preceded or concomitant to the diagnosis of sarcoidosis. The exclusion criteria were duplicate studies or reports, and if there were any clinical diagnosis of infections, of course, non-English articles were excluded, incomplete articles were also excluded. And this was how the time frame went in. Initially, we formulated the search criteria, which yielded which had the maximum yield on PubMed. Electronic search was carried on, and then we did a study review with all the co-authors, and selection was done using the Rayon software. And then all of the data was extracted to the Google Sheets, and then analysis was done with mean, average, frequency, and percentage. Now coming to the results, we had a total of 21 patients from 19 case reports and 1 case series, and mean age of the patients was around 45 years. But the range of age groups was quite varied. It was from 12 to 65. 57% of the patients were male, so it was pretty reasonable distribution. Coming to the geographical distribution, it was a very interesting representation from all over the world, with Japan having 5 patients and USA having 4 patients. And we had Asian representation, Middle East, everything going on. Coming to the clinical presentation, the most common complaint that the patient came in was non-productive cough. So it was present in 47.6% of these patients. And the next most predominant clinical presentation was dyspnea. Of course, they had sputum production, chest pain, fever, loss of weight, and other prodromal symptoms that we associate with an infectious disease. Coming to the comorbidities, type 2 diabetes mellitus, hypertension, and chronic kidney disease had 14% each. And this is not a surprise, since considering these are the most common comorbidities for any disease. And one thing that was very interesting was the stage of sarcoidosis. So I have borrowed this infographic from the Foundation for Sarcoidosis Research, which kind of gives the stages. So as we go on an ascending order, the stages are with increasing severity of the disease. So we had good representation from stage 3 sarcoidosis, where it's predominantly only in the lung tissue. Stage 2, where there is mediastinal lymph node and lung tissue involvement. There were only 1 patient with pulmonary fibrosis, which is end-stage sarcoidosis, and only 1 patient with stage 1, which is purely mediastinal lymphadenopathy. Coming to the radiological findings, 8 of 21 patients had abnormalities on chest X-ray. So the learning point was majority of the patients did not have an abnormal chest X-ray. So it was very important for them to have gone ahead and done a CT scan. In the CT scan, the most common radiological finding was nodular opacities and mediastinal lymphadenopathy, followed by consolidation and then ground glass opacities. Coming to the most interesting part of this, I think, is the predominant infectious etiology. As previously established, Mycobacterium tuberculosis and Propionibacterium acne did have good representation as a causative organism. However, SARS-CoV also had 23% of these cases were secondary to COVID virus, COVID-19 induced sarcoidosis. We also had some interesting cases of Chagas disease and some fungal infections. One was an aspergillosis and another was a histoplasmosis. 1 patient with HIV, hepatitis C, which also had some immunomodulatory issues. Regarding the lab investigations, ACE levels, which we commonly use to diagnose sarcoidosis, were abnormally elevated only in 7 patients. And hypercalcemia that we traditionally associate with sarcoidosis was seen only in 1 of those patients. Coming to the treatment, systemic steroids were given for 61.9%, almost 62% of the patients. And then in spite of giving steroids, 14 to 15% of the patients went ahead to get DMARDs like methotrexate. Out of this, clinical and radiological resolution was noted in 53% of the study population, which is very congruent with the kind of clinical resolution that sarcoidosis generally has.
1 minute.
The strengths and limits of the studies, limitations of the studies are, we were very careful about establishing the temporal association between the infectious disease and the sarcoid onset, and we had a good representation from many countries. However, the limitation is in we do have it's not a high level of evidence like a case control study or cohort studies. Hence, that would be a better systematic review for sure. So the conclusion is a clinical presentation, blood and radiological patterns, and treatment administered is what we kind of briefly overviewed in this particular review. And it is very important to have a good suspicion for sarcoidosis as a complication in those who do not improve after an appropriate antibiotic therapy for a recognized infectious etiology. This is important because there are certain external factors that we can prevent with vaccinations, especially in susceptible population. And this can also lead to new breakthroughs in treatment modalities. The other projects, because of my limitation, I'm also going ahead and doing a systematic review involving all the original studies. It's there in my final analysis stage. And these are the other projects that I'm collaborating with my other colleagues here. All right, thank you. These are my contact details. I'm not social media savvy.
Thank you, Sharanya. Very well done, and very happy to see a presentation that is visually appealing and at the same time quite descriptive for us to understand how sarcoidosis, pharmacological therapy like antibiotics can play a very big role in patients' management. My only question to you would be that would a meta-analysis be considered at any stage for a project of this nature?
Definitely, Dr. Nawaz. I think I started out with my inexperience, so I was kind of trying to see what I could do. But I think a lot of meta-analysis has been done in the past, and we could definitely build on and do a meta-analysis which is up to date. Because like I said, the last one that was done is in 2015 or 16. It is definitely an area that I'd like to work on right now.
Excellent. And we look forward to seeing that grow as well. Thank you very much.
Thank you so much for this opportunity.
Well, I'll take it away now. I'm so sorry for being late, but the presentation was so good. We didn't want to cut them off, and then we are having hard time choosing which is better than one over, and they are almost at the same scale. So I think you all are 8 winners, but we'll go very quickly. I'd like to invite our alumni from GRRSP, Dr. Munaza Afaq, to say a few words about what she would like to talk to you as a fresh graduate now. And then after that, we'll invite the class speaker, Dr. Mariam Asif, right after that. Each of you have 2 minutes to speak. Munaza, all yours.
Hi, everyone. I'm traveling, so not a very stable internet connection. But I didn't give up because I wanted to speak. Well, this is what GRRSP taught me. Don't give up, just keep going. So first and foremost, I would like to express my deepest gratitude to GRRSP for extending this invitation to me as an alumnus speaker. And it's both a privilege and a joy to be here today among such an amazing group of very soon-to-be Batch 10 graduates. And of course, in such a familiar and cherished setting. So I would like to congratulate all the scholars who have made this far in their journey on amazing research projects. It was really great listening to all of you on all the work that you have done so far. So being here back at the place where my journey in research began and evolved, it really feels incredibly special. I'm reminded of the rich experiences and the lessons I've learned from my time here. So I'll just quickly go through some of the things, and I'll try to be very objective. So I'm very excited and humbled to share my insights with you today. So first of all, the most important thing that I believe I learned was setting achievable incremental goals in life in order to proceed to reach your ultimate goal. So the 6-month duration at GRRSP, though it might seem very brief, but it's ample time for significant growth. It's steady mentorship. You learn to focus on small, manageable goals as stepping stones towards your ultimate aspirations. Like you'd write abstracts, you would submit work to conferences and create poster presentations. This is what you learn throughout your period at GRRSP. The second thing I would say is the importance of teamwork GRRSP emphasizes the value of collaboration. The program instilled in me the understanding that being a good team player enhances personal growth. The third thing I would say is personal and professional growth. We all harbor fears, and I believe the fear of failure is very common yet often unspoken one. And at GRRSP, I learned to celebrate every small victory and maintain the hope even when things don't go as planned. And finally, the enhanced communication skills. My recent interviews for residency, they were a testament to this fact that in GRRSP, you learn how to improve your communication skills. You learn how to articulate your passions more clearly, and you also learn how you can discuss confidently your setbacks that showcase your growth in your life, both personally and professionally. Though this is so little that I could just put it all together, but GRRSP overall has literally, I always believe in self-evolution, and I think GRRSP played a great role in that. So I would like to thank all the mentors who played that role in my life. And of course, all of you would, I'm sure, testify to this fact. So once again, I congratulate all the scholars and thank GRRSP for this opportunity. Thank you.
Thank you, Manaza. We are thankful for you coming online and saying few words of encouragement. And then we really appreciate that you're doing it during when you're traveling it. We wish you all the best, and we'll hope for a good news from you soon in next couple of months, or maybe in February. That'll be the right time, or March, whenever the results come out. Really appreciate it. Now, last but not the least, all of you have chosen one of the class commencement speaker, and that has been Dr. Mariam Asif. She has exactly 120 seconds, and then drum roll, please, for her to say on behalf of the whole batch what you want to share with the graduating class and our previous GRRSP alumni as well as incoming batch. Mariam, all yours.
Thank you so much, everyone, and hello again. They will, just a heads up, this is informal, so I might take some personal attacks on some of my teammates. So just giving you a heads up on that one. So I'll start by saying hello, everyone. It's truly humbling to be right in front of your screens as your class speaker. And of course, I want to kickstart my speech by giving a massive shout out to all of these awesome people who have threw my name in the hat for this gig. Thank you so much. Rest assured, I'm not going to take much of your time, but I want us to celebrate these three main achievements that we have unlocked in the past 6 months. The first achievement being, and the most important, is building this family of 10 amazing people. And right now I'm hesitant to say 10 amazing people as I see so many people attend our graduation. So this is more than just 10 people, I believe. I looked forward to our Sunday sessions. I started looking forward to Umay's and Amna's clueless faces when Dr. Kashyap was explaining something the first time. I look forward to Rupali's enchanting smile, to Ahmed's smart ideas. And I say it again, neurology is definitely your niche, Ahmed. And Amin's pronunciation of question, which she's still improving. And our Noos's mischievous remarks and fun banter with Dr. Kashyap. I look forward to Shania being able to maintain a serious face while we were giving her a hard time. Second, I think we should celebrate our creativity of our research projects and our ideas. Just simply 6 months back, we were struggling to find that one idea, right? Some of us took 2 weeks to come up with an idea, some 3 weeks, and some months, and a few of us even 2 months, right? But look at us now. We have these various research projects across the board in medicine, right? We're addressing social issues affecting female doctors or doctors in general. We're addressing concerns regarding polio. We're addressing medical topics in the area of cardiology, in pulmonology, hematology, neurology. We were introduced to the idea of social media projects, and we're just, I think it's just the start to a new concept that we have been introduced to. We explored the role of ChatGPT in the feasibility of medicine. So we're just come a really long way, right, in our terms of our creative ideas. Lastly, I really want us to celebrate our diversity. And diversity not limited to our creative ideas, but in fact that we are connecting from various countries currently. Diversity in our working styles. I feel the most important thing that I've come to realize in the 6 months is just not the part that coming up with the research idea is challenging. No, coming up with a team who wants your idea into being is in fact equally challenging. And now we have a team to collaborate in the future. So let's celebrate this diversity, right? But wait a minute, we are celebrating our creative ideas, we're celebrating our diversity. But would it even come into being if it wasn't for this platform, right? Thank you, Dr. Kashyap. Thank you, Dr. Zara. Thank you, Dr. Nawaz, for hosting this platform and in fact, allowing our ideas to come into being. Organizing those extra sessions, working through our conference abstracts late at night, and just keeping up with our Nautanki or drama. Thank you so much. Means tremendously so much to each and every one of us. I hope I'm echoing the voice of all my colleagues, my family, and that brings us to an end. Thank you so much, all of you.
Thank you, Mariam. This was fantastic. Absolutely the most Nautanki batch ever, but that was in all a good humor and sense. There are many alumni are here, and I can tell them with confidence that if you would agree, and we'll give you some chance to speak if you want to stay later, that this batch has been the most productive batch so far, and you're going to agree with the amount of products these guys have put together. Now, very quickly, we are running late. Dr. Arshad has prepared this commencement graduation speech, graduation certificates and awards. So I would like her to give away the certificates and awards. Zara, all yours, and please drum roll, anticipation, and whatnot.
Hello, everybody. Welcome to the last segment of this graduation ceremony. We all know where you were the first day we started and where we are today. This is not the end of your journey, but another start to another beautiful journey. So I will have your graduation certificates and some awards, which will be based on the presentations that you've given today and your commitment and engagement throughout the 6 months. So drum rolls, everyone. First off, with your graduation certificates, the first certificate goes to Ayman Parveen Afzar. And as we go, you can turn on your mic and say just one line if you want to say, or just a thank you even.
I'm so
The next
glad
graduate.
Yeah, I'm sorry. Please go ahead.
Go ahead, Ayman, go ahead.
Yeah. I'm so glad, and these 6 months went by so quickly. I'm looking forward to collaborating with you all in any other way possible. Thank you.
Thank you, Ayman. The next graduating scholar is Amna Hashmi.
Thank you. And I'm actually so sad this is ending. Like, I'm so sad, but I'm so looking forward to collaborating more and just keeping these ideas rolling.
Absolutely. The next graduating scholar is Aranus Ahadi.
Thank you, everyone, and looking forward to more collaborations. And thank you for just keeping up with me. I know you guys were patient with me.
Thank you, Aranus. Next up is Ume S. Faisal.
Thank you, everyone. I'm so thrilled. And Dr. Kashyap, Nautanki abhi baki hai.
Absolutely. We know that for sure. The next graduating scholar is Rupali Dahiya.
Thank you, everyone, for making this day possible. And these 6 months have flown like a wind, and I want other 6 months and many more years to come to work with GRSP further. Thank you.
I would definitely agree to that. Next up is Ahmed Yar Hassan.
Thank you, everyone, to the mentors, to the scholars. It's been a very fruitful 6 months, and I look forward to using what I've learned in these 6 months for the rest of, hopefully, my career.
Thank you so much, Ahmed. Next up is Mariam Asif,
Thank you so much,
our
everyone.
very own class speaker.
And I think you have had enough of me for today. Thank you so much, everyone, once again.
Next up, last but not the least, is Sharanya Santhi.
Thank you so much. It's been wonderful working with such driven people. I have learned a lot. Thank you.
Thank you so much, Sharanya. And now for the moment of truth, the performance awards. So,
Zara, for 1 second, there, I think so. We had a hard time. You guys were so close by. All of you are a winner, but if we give award to every single person, then they'll defeat the purpose. So we had to pick and choose somebody I think in somebody who has done well, either in collaboration, which we are big on, engagement, and then some presentation today and overall. So Zara, take it away, please.
all right. So the first award is going to be the Best Presentation Award, which goes to Rupali Dahiya. Rupali, would
so
you
much.
like to say something?
Thank you so much. I was really scared, like I prepared the presentation at the very last moment. And thank you so much.
Thank you, Rupali. You were really good
Speechless
with the
right now.
presentation. The next award is the Most Collaborative Scholar Award, which goes to Ayman Parveen Afzar.
I'm so glad it couldn't have been possible without you all. Thank you so much.
It couldn't have been possible without your engagement all along, Ayman.
Oh, thank you so much.
Next up is the Most Engaging Scholar Award, which goes to Mariam Asif. And we all had expected that.
Except for me, I believe. No, thank you. Thank you again, everyone.
Next up is the Rising Scholar Award, which goes to Ume S. Vessel.
Oh my God, thank you so much, everyone. This means a lot.
And another one in the same category, actually, which goes to Sharanya Santhi.
I did not expect this. I'm quite old to be a rising scholar, but thank you so much.
Thank you so much, everyone. We wish you the best from this point onwards, from where a new journey begins for you, where now you're not just a beginner in research, but somewhere in the middle, where you have a lot to talk about research. Thank you for bearing with us all these 6 months. And we are extremely, extremely proud of everything that you've done with us these 6 months.
I would like us to, those who are, this is a good time, we're going to take a picture. If you are joining it, if you can turn on your cameras, and then if you can put up graduation hat, if GRRSP10 faculty members are keynote speaker, please do so. You go into a video section and you turn on the choose video filter, go down in third or fourth row bottom down next to umbrella, red cap or something, there is a graduation hat you want to put down. We'll take a picture and then we'll see if our other alumni, if they have any words to share with them. I see Smitesh and Divya sharing their video, so they can definitely go first. So let's take a quick picture. I'm looking at Ram, Pranjal, Claire, Maham, and Hari to see if you want to share, you want to turn on your camera. I'll give you 5 seconds. 3. Duta, if you can share as well, you're the only one. Let me move people around. I can't. Okay. No. Okay, we are taking it. Ready? 3, 2, 1. I like it how Dr. Faisal has done it. I'm going to take one more picture. Everybody's eyes are open. They are good visibility. I'm going to take one more picture. Give me 1 second. As we are taking these pictures, well, we should not start talking. So I'll just save it. 2. And one more. 3, 2, 1. Yes, and we're gonna do a funny picture after that, and that'll be our last picture, I promise. GRRSP. then 3. And any funny picture, anybody wants to make funny faces, they should not be obscene and vulgar, but by all means, go ahead and go crazy. This will end up into our website or somewhere on social media. So any funny pictures anybody want to suggest? So you have 3, 2, 1. Yes, some good stuff has come out. I think that'll work. Smitesh has not changed at all from his funny and serious picture both. With that, I would like to, those who need to leave, by all means leave, please. But I'd like to invite Hari, Smitesh, Divya, or anybody else who are from the alumni batches to say a word or two what they felt about the graduation and projects, and maybe invite a couple of our future graduates as well. So by all means, go ahead. Hari and Divya. Please unmute and you're going to say anything. Go ahead.
Yeah, no, I was going to say some very excellent presentations. A lot of them were very well prepared, and a lot of information on how to do effective, systematic reviews, which I thought was excellent to see, and especially have a, more of an interest for pulmonary topics. So I found, the sarcoid topic also quite interesting. So that was of particular use for me. So, but good job, everyone. So,
Divya.
Congrats to everyone who graduated from this class. It was nice to see all your amazing presentations from neuro to pulmo to cardiology to the WISE talk and impact F. It was amazing presentations from each and every one of you all. So awesome work there. I'd like to say, as we continue in your journey in research, kindly continue this research work as you move forward in your life. Build good collaborations, and of course, as you move ahead, pull people up as you go, and all the best.
Smitesh, and probably we should invite our keynote speaker as well to say a few words in the end. Smitesh.
Yeah. Hey everyone, congratulations on the graduation. Welcome to being the alumni. And I totally agree. This was entirely different when I'm from batch 6. So we have come a long way, and it's great to see everyone doing 2 projects. That's the norm now, and we didn't have that back then. So we are definitely growing. And as Zara mentioned, this is just the first step. The opportunities to collaborate are endless, and it's what you guys make of it. So thank you so much for being the part of this alumni.
Dr. Smitesh is an incoming faculty for January batch as well. So see, you are a member and a scholar, and you can become after 2-3 batches as a faculty too. So Crystal, sir, do you have any comments, thoughts now? You might have seen some presentations and then the activities in GRRSP.
With pleasure. So I actually mentioned the example of the multipotent stem cells that differentiate after showing commitment to a cell line. And this is what I'm seeing here. All of you has apparently a different commitment, some people with neurology, some people with hematology, and everybody became really creative in finding a primary topic and study design to study this. And I have to say that social media research is something not so common outside this group. And this is very important because this is exactly what surrounds us. And I really like the fact that many of you combine this either with a relevant editorial to gain more attention, or even with a relevant, very fast track systematic review of a less known topic. Very clever, great outputs for people who, I presume, and I'm pretty sure that already have studies or work in the background and do this on their free time. So congratulations to all of you, and I just wish that you remain equally and even more creative in the future.
Very well said. Fantastic. Maham, I don't know if Ram or Pranjal, do you have any quick comments? Maybe a sentence and a word? 3, 2. Otherwise, Maham or Varun, your incoming batch. Go ahead, Pranjal.
Hi, no, it was definitely very interesting to see people presenting very well and very organized, and all the different faculties, different regions, different faculties, different interest converging together, but learning how to carry on in the same fashion. So definitely, it was very
Inspiring, right?
Inspiring. Yes.
Love it, love it. Ram, do you have any thoughts? Unmute, share. 1, 2, 3, 4, 5. he moved away. All right, quickly, Maham and Varun, if you have any thoughts as an incoming batch people, now you know what to expect. Maham, go ahead.
Yeah, congratulations everyone for graduating. And all of your presentations were really great. And the topics were really unique. And yeah, thank you so very much.
Varun, 10 seconds. 10, 9.
Thank you so much for the opportunity, Dr. Kashyap. These presentations are really inspiring, and congratulations everyone for the graduation. And I can't wait to join in the upcoming batch. Thank you, everyone.
Perfect. All right, we are way late than what it is, but now we had excellent presentation. Thank you so much for being here. Congratulations to graduates. Welcome to alumni. You'll be added to the alumni WhatsApp group now, which very few people are so far. So you will make it to more than 50 very highly selected people who have gone through GRSP batches now. So welcome to GRSP alumni and see you on the other side. Take care.